saying, please remember that early menarche and late menopause are risk factor because the statistics says that, that when they investigate women with breast cancer and women without breast cancer, they found that more frequent the women with breast cancer had early menarche or late menopause. And it is a fact that we need to know. So it is an interesting topic. I'm going later to reinforce the risk factor for breast cancer, but it is a way that can be tested, okay, cellular applied. It's important to know who has more risk than other for breast cancer, because then maybe the screening needs to start earlier than in the general population. In the general population, the screening for breast cancer starts in their 40s, yes. But in patients that have especially increased risk factors, probably need to start earlier and need to be more strict. Another question related with the topic: which of the following female clients is at highest? So now, as I always insist, when you see this term, okay, highest, most, first, next, most important, this question is difficult. Why is difficult? Because this question is a prioritization question in which maybe there are more than one risk factor, but you need to find the strongest, okay? So which of the following female clients is at highest risk for breast cancer? And then we have a 30-year-old active runner, so exercises 30 years, and so it's relatively young, no? With breast fibroadenoma. I don't know if you know what is fibroadenoma, but those are some tumors that appears at younger age, are unique, and are rubbery in its consistency, very well delimited, movable, non-painful, don't change, don't modify with the menstruation, and are evaluated by the doctor with ultrasound and needle biopsy. It is a condition relatively frequent. 40-year-old with twins and a history of mastitis on one breast. A 54-year-old with a 21-year-old child, so had a child, and had the child when she was 33, and mother who had breast cancer at 68. 54-year-old, the same age, with two young kids, okay, I don't say the age, and a sister who had breast cancer at 35. So when we see this question, we need to know that the most important risk factor for breast cancer is aging. So the most common, yes, is aging. Breast cancer is very rare in young people. The risk of breast cancer increases with the age. So we see here first the age, and probably based in that, we can, rule out, we can eliminate these two clients, because fibroadenoma is a benign condition that has no relation with breast cancer. The same as the fibrocystic disease of the breast. The fibrocystic disease of the breast are bilateral and are multiple lumps, are painful, and especially they enlarge before and during the menstruation and deflate like 1 week after the menstruation. Those are also benign conditions. Fibroadenoma and fibrocystic disease of the breast are benign conditions that are not related with breast cancer. Maybe can be confused with breast cancer, maybe make more difficult for the doctor and the radiologist to visualize breast cancer behind this benign condition, but this benign condition doesn't produce cancer. So we can rule out at 30 and 40 years old because mastitis is also a benign condition that is not related with breast cancer. So we need to deal with C and D. They have the same age. They are both at risk of having breast cancer. And both have children and both have relative, first degree relative with breast cancer. Which one you think is of these two the one that has the highest risk?
The last one.
C.
And why?
D.
First
And
line.
C.
No, no, no.
D.
C. It's
First
C,
line.
Professor.
D.
C. Mother is most important history family.
Yeah, C.
is more
I
important
agree.
than
The
sister.
lady D
Closer.
later.
Yes.
I
His
think that is
mother-
D
Direct
because
generation.
Okay, so now recognize,
And you
because
see, his sister had hers at 35, and she's closer to the age of when her mother had hers. I say C.
okay, so notice that there is a content, this is polemic when deciding that, and it makes difficult. The family risk factor, the family risk factor relation is the first degree family member. First degree family member of a person are the first degree family members are the parents, both parents, the siblings, and the children. Okay, so first degree is defined as your parents, your siblings, and your children. In this case, we need to give importance to the female first degrees relative. So in reality, for statistic, the way that has mother is the same way as sister. Okay, so thinking that mother is more important than sister has no sustentation in evidence. So first degree, a mother is first degree, a sister is first degree. The interesting here is that any woman without family with breast cancer, as growing older, has more probability of developing breast cancer. But when a woman develops breast cancer so young, it's because probably there is a big, huge, strong genetic influence that predisposes this young woman to have breast cancer. So if I develop colon cancer, is expected and old. But God forbid any of you that are much more younger than me develop colon cancer, obviously is because you have a problem, you have a predisposition. My problem is growing older, and the older that you are, the higher the risk of having cancer. If a young person has the cancer that is usually seen in an older person, it's because this young person has a strong genetic influence inherited that predispose so strongly this person to have cancer that appears much earlier than usual. So when you weigh, and is supported by the book, the first degrees are relative with cancer, and you have one younger than the other, and especially very young like this one, is evidence that in this case the genetic influence is much heavier in the younger relative. So probably the best answer for this question is D as in diamond, because the sister had breast cancer at 35. This sister of this woman has the same parents and the same genes as the other woman. Yes, and for that reason, the genetic is more important in this case. Summarizing, in similar situations, similar age, and similar characteristic, if two different clients have first-degree relative with cancer, a cancer with genetic influence, the sooner the cancer appears in the relative, the strongest the genetic influence. Is clear my explanation? It clarifies the concept?
Yes, Professor.
Yes, Professor. Yes.
Is D.
Talking about this is a little small, trying to see that. I forgot to enlarge the letters. Which of the following represents the highest risk for breast cancer? Heavy smoker, BRCA1 and 2, mother with breast cancer, sister with breast cancer.
B.
B as in boy,
B.
or two as in, yes, exactly. Because this is the kind of oncogenes that provide a strongly high risk of inheriting the risk for developing breast cancer. With this gene, you can also have ovarian cancer, colon cancer, etc. But we are talking here about breast cancer. So these BRCA1 and BRCA2 genes are the evidence that breast cancer in some people, not all people, can be genetic. And because it's genetic, can be passed from generation to generation, so can be passed in the genes. Those are genes that are easily mutating, and when they mutate, confers advantages to the breast cells, and now the breast cells have no control. Nobody can control those cells and start growing independently, and it's stealing the space and the blood supply and everything from the normal cells, and can be as aggressive as to go to other parts of the body to produce cancer. So now you understand that if a person inherits those genes, is a very high risk of breast cancer. Usually, those genes are called the Angelina Jolie genes, no? Because Angelina Jolie tested herself and she had those genes inherited from her mother, who died of ovarian cancer and had breast cancer, and she decided to remove her breasts and ovaries, okay, because the incredibly high risk that brings having those genes. So now we have a better understanding that the breast cancer has risk factors. And any woman can have breast cancer, even not having these genes, even not having any relative member with breast cancer. This kind of general population women tends to develop breast cancer as they grow older. Okay? But in some cases, the breast cancer has a higher, strong, and definitive, well-identified genetic influence. And then you start seeing in those families, repetition, okay, recurrence of breast cancer in different, generations. And even certain genes can be identified that are oncogenes, like BRCA1 and 2. Okay, so clarify the concept. In general population, being old, ¿cómo se llama? Taking estrogens after menopause, having early menarche, late menopause, not having pregnancies, or having the pregnancy late after 30 are risk factor in the general population. Surgery, infections, a trauma, fibroadenoma, fibrocystic disease are not being associated with increase of breast cancer. Smoking and drinking in excess, yes, has been associated as risk factor for breast cancer. Okay, it is a fact. So here I summarize here. Okay, that age is definitively a common risk factor for any woman. The older, the higher. And this risk increases and doesn't stop increasing as the woman grows older. So aging is the most important. For that reason, any woman after they are 40s, independently of having or not risk factors, other risk factors, need to start screening her breast for breast cancer. Of course, if a part of that you have genetics, of course, a first degree, yeah, we discussed what is a first degree with breast cancer is a risk factor. Okay, and if you have a first degree with risk factor, the younger that this first degree relative had the cancer, the higher your risk, because it means, oh my goodness, the fact the risk is strong. And for that reason, John, okay, she had, okay, breast cancer. My sister had breast cancer, and etc. And of course, the specifically identification of BRCA1 and 2 is like, say, there is no discussion. Of course, if a person had breast cancer in one breast before, is a high risk of having breast cancer in the other breast or in the remaining breast if only a lumpectomy has been done. Receiving radiation in the chest for other causes is also something that can increase the risk of breast cancer. Early menarche and late menopause are risk factors for breast cancer. Newly paritetic, which means no babies, or having the first child after 30 is considered a risk. By the contrary, pregnancies, especially before the 30s, are protective. And breastfeeding is also considered protective. Hormonal replacement therapy, estrogens after the menopause, is a risk factor. Obesity is a risk factor. Important. Obesity is a risk factor. You need to know that adipose tissue, which is bigger when you are obese, produces estrogen. So a woman that is obese has more estrogens, more estrogenic stimulation, even after menopause, than a woman that is not obese. So this is the probable explanation or theory that's explained why obese women have higher risk of breast cancer in comparison with thin women. Not only breast cancer, ovarian cancer and endometrial cancer, uterus endometrial cancer, increase this risk with obesity for the same reason, because adipose tissue produces estrogen. On the other hand, osteoporosis, the process of loss of calcium in the bone that happens after menopause because of the estrogenic insufficiency, tends to be less severe in obese women compared with thin women. So being thin, is a risk factor for osteoporosis because thin women don't produce estrogens because has no adipose tissue after menopause. And don't forget that alcohol and tobacco are risk factors. Those are, late findings in breast cancer. Maybe I suggest you to know this is French peau d'orange, and this is a very serious, advanced, horrible prognosis type of cancer that is disseminated in the lymphatics of all the breast. And because the skin is swollen, the pores of the skin are, making pits, are sunken, and give this aspect of the skin of the orange, the peel of the orange, yeah, and the peau d'orange. It is a very, very aggressive form of cancer. Notice that the cancer grows in the ducts that ends in the nipple. So this is the most common form of cancer, the intraductal. So a tumor that is growing in one of those ducts can adhere, can't hold the muscle and the ribs that are here, and also can hold the nipple, and for that reason can pull the nipple inward. So a new onset for first time of nipple retraction is something concerning. There are women that are born with nipple retraction. This is not the case, but a new onset, a new development of nipple retraction is concerning. And this is the other finding in late breast cancer. The dimpling that occurs because the same mechanism, the tumor is here, so the tumors invade the skin and adhere the skin, grab the skin, and also grab, the muscle and the ribs that are here, and start, shrinking and start, pulling the skin, and the woman is going to observe this dimpling, when, doing the breast self-examination. Because those are late findings, the present tendency is to recommend basically mammogram for the early diagnosis. The findings in breast self-examination are generally late. And the tendency of the people that know about this is to promote the mammography, not the breast self-examination, because the breast self-examination diagnosing so late the cancer has not demonstrated reduction of the mortality by breast cancer. And this is the modern tendency. Again, you can go to the literature to find this evidence, this discussion. But I can assure you that Nclex, yes, make questions to know if you can identify women that have especially high risk for breast cancer, because these risk factors that are mentioned here and are brought here from the book, from the evidence. And this is what you need to try to memorize. And we just discussed that, and the discussion was interesting because some of you clarify some misconceptions. A 24-year-old female client whose mother and sister were diagnosed with breast cancer asked the nurse about the ways of decreasing her risk for breast cancer. Which of the following actions could help reduce the risk for breast cancer? Practice annual mammography, take oral contraceptive, avoid consuming alcohol, delay pregnancy as much as possible.
A.
C.
D.
Okay, obviously C is a good answer, because we can eliminate this, because early pregnancy is protective, it's not a risk factor. Oral contraceptive neither cause nor protect against breast cancer. So taking oral contraceptive does not prevent breast cancer, does not cause breast cancer, but doesn't prevent, breast cancer. Taking oral contraceptive, the pill, can prevent, can avoid, can decrease the risk of any type of cancer. Do you know something about this? No? Nobody?
Is it cervical cancer?
No. By the contrary, when you are taking oral contraceptive and you are not afraid of becoming pregnant, then you tend to avoid condom in your partner. And because cervical cancer is acquired through sex, because the cervical cancer, 99% of the cases, is associated with human papillomavirus. And the best way of avoiding papillomavirus is the condom, yes? When you are taking oral contraceptive and you say, condom for what? I don't need condom. I cannot become pregnant, okay? And then condom is not used because you are taking oral contraceptive. even if oral contraceptive is not the cause of cervical cancer, the fact that when you are taking oral contraceptive, you don't use condom, this could increase your possibilities of catching the human papilloma virus in cervical cancer. Making a clarification. The answer is ovarian cancer.
But there is some type of ovarian cancers that certain oral contraceptives like help you to not get it.
Okay, so yes, what we need to know is that oral contraceptive can decrease the risk of ovarian cancer. The mechanism is not well understood, but it is statistics. They take a group of women with ovarian cancer and a group of women without ovarian cancer, similar age, similar characteristic. And they found that the women without no ovarian cancer take oral contraceptive more frequent than the women that have yes ovarian cancer. So they know that oral contraceptive, okay. A mammography can prevent breast cancer.
No.
No.
Can detect early.
Exactly. So mammography is secondary, okay? Secondary prevention, okay? Is a early detection. Of course, when it's early detected, you prevent what? Death, metastasis, pain, suffering, etc. So early detection when the cancer is very small, is microscopic, is not palpable, you don't palpate anything, is very good because your risk, your possibility, sorry, of cure are very high. Remember that when we avoid the disease from happening, from occurring, like for example, a vaccine that is effective, it is primary prevention. First, primary prevention. But when we diagnose the disease that is, yes, is happening, is occurring, is not prevented, the disease is happening, but we catch it so early that can be cured or controlled. This is secondary prevention. While you are preventing them, because the disease happening, you are preventing the death. Okay, and many other complications. Very good, good example. Another question, I'm telling you that all these questions are topics that have been discussed in question in English by students that already took the English. The nurse is teaching the technique of breast self-examination. In which areas should explain the nurse are tumors more frequently found? Select all that apply. So I brought here a representation of a breast. In this case, is a right breast, no? Because this is the armpit, this is the axilla, okay? And you know that the breast extends to the armpit, to the axilla, okay? So this is the tail spans. Spence was a guy who described this tail of the breast, okay? And don't forget that there are a lot of lymph nodes in the armpits, in the axilla, which drain, okay, the breast. So once we refresh our anatomy, okay, let's see, yes or not, internal, inner, upper quadrant. So this, yes or not? They're asking for the most common. No, it's not common there. Upper and outer quadrant. So this one.
Yeah.
Yes.
Yes. Behind the nipple.
No.
Yes. Okay, tumors can be found behind the nipple doing this. Do you see that here?
Yeah.
Do you see that here? Yes, can be found there. It's very important to evaluate the nipple, even to squeeze the nipple to see if there is blood coming out. Sorry. Okay, so I think that behind the nipple should be selected. Axilla, of course, yes,
Yes.
it's a
Yes.
classical site of breast cancer. And the others are not, okay? The upper inner quadrant is the same as the other. Lower outer quadrant, which is this, no. So summarizing, behind the nipple, in the external upper quadrant, and in the axilla are the site where more frequently tumors are found. A client is discharged with the medication tamoxifen after right breast lumpectomy. Lumpectomy is when there is a very localized cancer and they only need to remove part of the breast, not all the breast. For ductal carcinoma, the most common form of breast cancer is ductal carcinoma, a cancer that grows inside the ducts that that produce and transport the milk. Which action the nurse explains has this drug preventing recurrence of cancer. So how works tamoxifen? It is a chemotherapy that inhibits mitosis. Remember, the mitosis is the cell division that allow one cell in dividing in two cells. And then these two cells, each one divide in two cells. And this way can multiply in few hours a lot. And you know that there is a control of this cell division in the normal cells. They have control. They need to ask for permission. But in breast cancer, in any cancer, any cancer, the mitosis is without control. So the cancer is growing very fast. So the fast growth of the cancer is a characteristic of any cancer. Some cancer grow faster than others, but it's a common characteristic of cancer. And this is what explains the mechanism of action of the chemotherapy. That chemotherapy targets specifically cells that are dividing very fast, that have a lot of mitosis, okay? So it is a chemotherapy that inhibits mitosis. It is an anti-tumor antibiotic. There is a type of cancer medication that are called anti-tumoral antibiotics. For example, bleomycin. Okay, bleomycin is one of them. Is an antibiotic, but is anti-tumoral also. The other is an anti-estrogen drug, and the other, it increases the white blood cells. So what do you think is the mechanism of action of tamoxifen?
A.
Number one.
Number one. Okay, so you need to know tamoxifen because tamoxifen is super frequent tested in NCLEX. Tamoxifen is a medication prescribed to women with breast cancer that in the analysis and the biopsy demonstrates the presence of estrogen receptors. So those cells, those cancer cells that you see here, still have the same as the normal cells of the breast, still have receptors of estrogens. Why women have big breasts? Because the woman produces estrogens in the ovaries, and the cells of the breast have estrogen receptors. If a man injects estrogens, the little breast that we have will grow. Why? Because even those cells have estrogen receptors. Okay, so if you have a breast that grows, is because this is a woman that has estrogen. And it means that the cells of the breast has estrogen receptor. But if one part of this breast develop cancer, the cancer originates in the breast, and there is a possibility that the cancer cells still has this estrogen receptor. And in this case, estrogens, even the normal estrogens that a woman produces, because it's a woman, is going to stimulate the growth of the cancer. So one way of holding or repressing the growth of breast cancer when it already appears is avoiding the estrogens that a woman has reaching the cancer cell, the breast cells, and stimulating the growth of the breast cancer cells. In two words, if you block estrogens in the breast, you can slow down or stop the growth or the recurrence of breast cancer. So tamoxifen is a medication that works as anti-estrogen. The answer of this is C, not A, is C. It is an anti-estrogen drug. Tamoxifen belongs to the family of the estrogen receptor modulators. Estrogen receptor modulators. Okay, and tamoxifen has a sister, and it's called raloxifene. So there are two medications that work similarly. Is tamoxifen, that is written here, and raloxifene. But both, okay, work, okay, inhibiting the estrogen receptors in the breasts. But in the case of raloxifene stimulate, no inhibit, stimulate, no inhibit the estrogen receptors in the bone. And for what you think is use raloxifene? What is osteoporosis? Is a disease that appears when the woman has no more estrogens produced in the ovaries, stimulating the bones to store calcium. I'm going to repeat. What happens to a woman that stops having menstruation? It stops producing estrogens. And women need estrogen in the bone, in the bones of the skeleton to keep the calcium inside the bones. So when there is no estrogen in the woman because the menopause, the calcium start leaving the bones because there is no more stimulation of the estrogen receptors in the bone. I said that raloxifene stimulates the estrogen receptors in the bones. So now, who can tell me quickly? Don't waste time. For what is used raloxifene?
Osteoporosis.
For osteoporosis.
Osteoporosis.
For the treatment of osteoporosis.
Osteoporosis.
For the treatment of osteoporosis. But tamoxifen is used more to block the estrogen receptors in the breast. So did you notice that this kind of medication in some parts of the body block and in some parts stimulate? That's why they are called modulators. You understand? Cannot be called blockers, cannot be called stimulating or agonist. In some parts stimulate, in some parts inhibit, and for that reason are called estrogen receptor modulators. It gives the option that in some parts stimulate, in some parts inhibit. Stimulating the estrogen receptors in the bone is good because it treats or prevents or delay the development of osteoporosis. Blocking the estrogen receptors in the breast is good for women that has or had breast cancer and their cancers had estrogen receptor, because cancer is like a fire and estrogen is like gasoline. If you add gasoline to a fire, it increases. So estrogen is like gasoline for cancer, breast cancer. Yes, it's going to grow more the cancer. If you block Okay, if you block this gasoline, if you block this estrogen from reaching the cancer cells in the breast, you are doing good because it's going to delay, inhibit, repress the growth of this cancer. So now you understand the role of tamoxifen in the treatment and prevention of the repetition, the recurrence of breast cancer in women that had breast cancer with estrogen receptors. Of course, not all women are taking tamoxifen because not all women have cancer with estrogen receptor. But this is doctor business. What we need to know is how it works the medication that we are going to give the client. Is taken orally and is taken for a period of time. Okay, so tamoxifen, here is tamoxifen, belongs to the family of the estrogen receptors modulator. The other medication of this group is the raloxifene that is used for osteoporosis. But then there is one detail. It's a very complex medication. It's a medication that doctors need to study in detail because women have estrogen receptors all over the body. And in some parts stimulate, in some parts inhibit. So it's very complex. We don't need to go to complexity. We need to understand the basic. And the explanation that I gave you is the basic. But there is a detail that I need to add to the explanation. At the levels of the veins of the legs, and at the levels of the coagulation, the capacity of the blood to coagulate, the tamoxifen and the raloxifene has a defect, has something not good. You know that all medication has pros and cons and need to be placed in the balance. Okay, the defect of those medications is that stimulate the coagulation in the veins, stimulates the possibility of developing deep vein thrombosis, thromboembolic disease originated in the veins. So any woman taking either tamoxifen or raloxifene need to be very careful with the possibility of developing DVTs. You know what is DVTs, deep vein thrombosis. And for that reason, should avoid being sitting for a long period of time, avoid dehydration, avoid tight, clothing, and do exercise. Use compressive stocking, antivaricose veins stocking. Maybe they are going to recommend low doses of aspirin. And any sign or symptom of unilateral asymmetric swelling of the lower extremities, tenderness in the calf, etc., is a concern that should be reported immediately. Understood? So it is an important adverse effect. Remember that for anchors, each time you study a medication, that is important, and there is a lot of medication that you don't know yet and you need to know because are important, because are frequently prescribed. You need to study two stuff, how it works, so which one is the desired outcome, and side effects or adverse effects could be risky for the client, and you need to be monitoring just in case the client has the bad luck of having this adverse effect. There are other details, but this is the most important. Tamoxifen can produce hot flashes. Tamoxifen can produce stimulation of the endometrium of the uterus, increasing the possibility of endometrial cancer, etc. But they are less frequent and they are less important than the risk of developing DVT. Patients that have breast cancer frequently has a mastectomy. And after the mastectomy, the lymph nodes of the armpits and the subclavian area are going to be removed. And then you need to know that there is a system that we don't mention frequently or we don't study frequently, that is a system of lymphatic blood vessels that drain the water, the liquid, the interstitial liquid, the water that is in the flesh of the body, but especially of the extremities. When this liquid is going to, flowing, is going to be flowing from distal to proximal, okay? And this liquid is going to end in veins in the chest, yes? But this liquid is called lymph. And when those liquids need to go through filters that are the lymph nodes. And when the lymph nodes are removed, then the flow of this liquid, of this lymph, is impaired, and then the flesh of this extremity can't get swollen, and it's called lymphedema. Lymphedema. The lymphedema is going to make the extremity in the side where a mastectomy happens swollen. And this swelling, having this flesh, this interstitial space swelling, increases the risk of catching an infection in this flesh, in cellulitis, etc. And for that reason, a part of the edema, which is ugly and is bothering the woman, there is an important need of education and prevention of skin injuries, nail injuries, etc. That could be the port of entry of bacteria, staph, or straps that could produce cellulitis and infection in the upper extremities. The drainage of the liquid should be improved, should be promoted, elevating the extremity above the level of the heart. So if the woman is on bed, and it is an Nclex question, which is the position of a woman after mastectomy, the important is to have this extremity with the lymphedema, the side of the mastectomy, elevated with pillows, and also when going home, when is sleeping, elevated with pillows, to favor the gravity drainage of the liquid. And during the day, instead of having the extremity dangling, hanging there, to have a sling that reduce, okay, the accumulation of liquid. And of course, it's important to avoid taking the blood pressure there, because when you inflate the blood pressure cuff, you are harming even more the circulation, or any kind of puncture, acute check, IV, ¿cómo se llama? Drawing blood, etc., because it could be the portal of entry of bacteria that can produce this complication. The most common way of testing this is a real life scenario. Is a woman who had a mastectomy and has lymphedema and is doing something that tells you that the woman needs teaching, needs more education. Like, for example, cutting the nails herself, like, for example, doing gardening. So if you never did gardening, gardening is done with plants, with scissors, with horns, with dirt, okay? And it's a risk factor to have a skin injury, a thorn that is cutting the skin, piercing the skin, etc., etc. Because that even the student was very upset because they say it was unfair. Being asking for a woman with a mastectomy, having gardening, being this the answer. He felt this question. He said, it's not unfair. People do gardening. If you don't like do gardening, but people do gardening. This is my hobby, and you have a lot of injury when you do gardening. And a person that has lymphedema cannot do gardening. They're saying that working in the kitchen with knife should avoid that, etc., etc. So please use your mind, your common sense, and your imagination. That the question is in the Nclex. The answer is not going to be avoid injury in the hand. No, it's going to be a situation, a scenario, an activity, a hobby, or whatever that could be associated with injury, and this is the activity of the hobby that you need to teach the person to avoid. Having range of motion exercises are good. Doing exercise. Here in Miami, there is a group of breast cancer survivors, women breast cancer survivors that do, how you call that, roaring, or, canoe, okay, competences. And because, roaring is, remero, no, remos, is a good exercise. And don't forget that we are holistic in the implication of mastectomy for the woman, the brain of the woman, and also the husband. And there is a lot of work to do in this. There are very interesting qualitative studies in nursing that about this topic are very interesting. And the other that you need to know, well, those clients also receive chemo. The chemo is another topic. This is another day. We need to talk about a little more about chemo. But radiation is common in patients with breast cancer. And the problem, the type of radiation that is used in breast cancer and in the majority of the cancer, in 99.99% of cancer, the type of radiation that is used is called teletherapy radiation. What is this? It is a device, it's an apparatus that is able to produce gamma rays and produce that, accelerating the protons of substances that are inside the machine, and it is going to produce a type of ray or radiation that kills cells. So this radiation need to be centered, need to be focused specifically in the site of the tumor, because you don't want to kill the good cells around. So this radiation is going to be centered in the tumor, and is going to be centered in the lymph nodes, supraclavicular, infraclavicular, axillary, etc. So doctors that are specialists in that, okay, will use this radiation. The patient is going to this room where the machine is, and anybody is there, only the client. And the emission of this gamma ray is just seconds. Once the machine turns off, there is no more radioactivity. The patient is not radioactive and is going back to his or her room or his or her house. So if they ask you, can a pregnant nurse take care of a client receiving teletherapy radiation, a gamma ray radiation, this kind of radiation that is the most common? The answer is yes. The answer is yes, because the pregnant nurse is not entering with the client. Nobody is entering with the client in the moment where the radiation is turned on. And when the patient leaves this room, the patient is not radioactive. So there is not any risk for a pregnant nurse taking care of this client. The main problem, well, radiation produce a lot of symptoms, can produce diarrhea, can produce a lot of symptoms, depends on the site that is the radiation.
Hold on, Professor. Hold on, Professor. I'm so sorry. Let me have a question. Hello, Professor?
Go ahead, I'm here.
I'm so sorry. My name is Giselle. Okay, let me clarify. You say when the patient is inside the room, she need only the patient, no the nurse for pregnancy, but when the patient...
Anybody. Nobody, nadie.
Nadie. Okay, Professor, but when the patient stay in his room and the nurse he's care, the nurse pregnancy, he can care this patient, yes?
Why? Because the patient is not radioactive.
It's not radiate. Okay, okay, Professor. Okay.
Understood?
Yes, I'm clear, very clear.
Perfect.
Okay.
That's the idea. Okay. Okay. Radiation producing common a lot of fatigue. You need to know that as a nurse, a holistic nurse, what you expect when this client is coming from radiation and and while the radiation is received, a very fatigued client. So you need to plan standard and frequent periods of rest, etc., because there is a lot of fatigue as part of the radiation. And the other topic that is related with radiation and nursing is that the place where these gamma rays, this beam of rays enter in the skin can suffer inflammation. Okay, and this skin is going to have inflammation that could make the skin shrink, suffer atrophy, and for that reason need to be pampered, need to be cared a lot. So, for example, this skin should not receive sun rays, so no beach, no sun rays, no exposition to sunlight. This skin should be covered with cotton or soft clothing, because you don't want to use a jean or corduroy or some tough fabric in this. You should when you clean with water and a mild soap. No need of normal saline, no need of a sterile water, no need of anything special to clean the skin except soap and water, mild soap and water, but then pat dry, don't rub with the towel, etc., etc., etc. There is a question in English that what was wrong, and the patient had this red skin, and people know that in Walmart and Walgreens and CVS, they sell hydrocortisone cream, 0.1%, that is over the counter. It is a topical glucocorticoid that, glucocorticoids are the most potent anti-inflammatory medication. Okay, so the patient can be tempted to self-prescribe hydrocortisone in this red and irritated skin. Caca cannot be done. Glucocorticoids produce more shrinking of the skin, and this skin is already shrunk by the radiation. So those are examples of topics that had to do with the radiation. If you have, which laboratory finding you would expect in a client with metastatic, advanced and metastasis, breast cancer, polyuria, so it's peeing too much, and abdominal pain, low hemoglobin and hematocrit, or hyponatremia, or hypercalcemia, or decreased antidiuretic hormone. What reminds you this scenario?
Metastasis, I guess, is hypercalcemia.
This is a difficult question. This is a reproduction questions, and you got a very high level of answer. If you have metastasis, you assume that the metastasis can be in the bone. Bone has a lot of calcium, and then the calcium is going to be a shift from the bone to the blood, and from the blood to the kidneys. Once the calcium is in the urine, is going to have an osmotic action, sucking water from the body of the person, producing polyuria and dehydration. The same way that glucose sucks water from in the urine from the water of the body of the person, producing polyuria and dehydration, hypercalcemia produces osmotic diuresis, sucking, pulling water from the body of the person, producing abundant pee, abundant urine, diuresis or polyuria and dehydration. And because the calcium produces kidney stones, abundant kidney stones, the patient can have pain. And also hypercalcemia can produce abdominal pain and constipation. So this is the classical presentation of a patient with metastatic cancer in the bone. And the answer, hypercalcemia. Another English question that somebody had. The charge nurse is reviewing the protocol of care for clients with cervical radioactive implants with the new nurse. So now it is another type of radiation. It's called implant. It also is called brachy. Learn this name, therapy. Is tested therapy. Okay, so there is another type of radiation which is not teletherapy, is not tele-radiation, is not beam radiation, is not gamma beam radiation, is not these devices called linear accelerators or gamma knife, okay? These machines can be called gamma rays, no? Gamma rays, no? The rays that kill the cells, no? Gamma radiation, no? Gamma knife is like a scalpel with the beam of radiation that the radiologists, oncologists, radiologists can and can kill the tumor, no? Can be called linear. Yes.
Now it's called cyber knife.
Okay.
Use the gamma radiation, but now the instrument is called cyber knife.
Okay, so cyber knife. Okay, cyber knife is because cyber means that is using the computers and this, the cyber, space to do that, no? And cyber knife, gamma knife, a linear accelerator, etc., etc. Okay, so those are the fancy names that people give that, but to make it very impressive, no? And that's it. But this is called teletherapy, yeah, teletherapy or beam therapy. Okay, now another type of therapy, radiation brachytherapy, and the brachytherapy is not with this machine; it's with something called implant. So now there is a device, could be a rod of a substance that it emits radiation. This substance emits, okay, radiation. Can be radium, okay, cobalt, etc. This is not our business. This is not nurse business. Okay, radiotherapy is not something that we manipulate. Radioactive stuff, we don't manipulate that. There are other experts to manipulate that. But we have the clients with this device. So this device could be a piece of metal that is placed in the body of the person. So the most common is in the cervix of a woman. The uterus has a cervix, okay? In the cervix is place of the woman because the woman has an advanced form of cervical cancer. Also can be placed in the prostate gland of a man with prostate cancer, or can be placed in wherever the doctors want. But we need to know that when those implants are used, it's called brachytherapy, and it is different. It is different from the previous. Why is different this brachytherapy? Okay, because now the client is carrying the radiation. So now, if the client is having brachytherapy, and you know what is brachytherapy? If you don't suffer of attention deficit disorder and you're paying attention, you know what is brachytherapy. And has an implant, can a pregnant woman, a pregnant nurse, okay, take care of this client?
No.
No.
Why? Because this client is, yes, radioactive. Capiche? Okay, so you need to know the difference because a nurse should know that. And you are going to be working with patients with cancer. Cancer after cardiovascular disease is the most common disease. Okay. So now the question says, the charge nurse is reviewing the protocol of care of a client with cervical radioactive implant with a new nurse, which statement tells the charge nurse that the nurse requires more teaching. What means this? It is a question, a negative question, that something wrong must be found in the four options. So visitors cannot stay more than 30 minutes in the client's room. All soil linen must remain in the room until the client is discharged. Wakala. The client must always wear a dosimeter. Visitors must keep 6 feet from the client's bed. What do you think is here wrong? Because when they say more teaching, what you are going to find here is not the correct, it's the wrong. So this is the first strategy for the people that are very fast, wrong runners, Speedy Gonzalez. You need to know what they are asking you. You cannot answer what you want. You need to answer what the test is asking. Okay? Okay. So what is wrong here?
C, is the nurse the one who have to have the dosimeter,
Very
the
well.
client.
Very, very well. So first we need to know what is the dosimeter. Dosimeter is a badge, is a device that has a sensitive material that can change and can count, let's see that this way, can count the amount of radiation that you are receiving. And it's individual. Each person has his or her own dosimeter and is counting in a period of time how much radiation you are receiving. And of course, is used by the personnel that is working in areas where radiation can be present. So in X-rays departments, in areas where brachytherapy is done, etc., the people that are working in those areas must be all time carrying this dosimeter. Why? Because the people that take care of the radiation safety and environmental control are periodically checking your dosimeter to see if you have received a limit of the safe dose. Always there is a safe dose of radiation that any person can receive. In this moment, by the way, all we are receiving radiation. We're receiving cosmic radiations. We're receiving radiation from our devices, but this is safe dose of radiation. And this is determined in this dosimeter when there is more frequent, more intense. Period. The one that must be wearing this dosimeter is the personnel, is the nurse, is the doctors, even the whoever is working in the area, but not the client. It doesn't make sense. The client is receiving therapeutic radiation. Okay, the rest are correct. The farther that you are from the source of the radiation, the better. And it is said in this brachytherapy, keeping a distance of 6 feet, similar to the body distance, the social distance, the physical distance of the infection control, the better. Second, the linen of the client that is receiving, this radiation should be kept in the room. The reason is safety. There is a remote but possibility that the implant could be dislodged. Dislodged is coming out, means that it's coming out the vagina of the woman. In this case, could be hidden, entangled, and hidden in the linen. And a CNA that is working very fast could not see that or could not know what is that and could take this linen to the laundry. So now we have a radioactive contamination outside the room where this implant is supposed to be. And to prevent this possibility, no linen can leave the room until the client is discharged. The doctor come, take the implant, put that where it need to be placed, and say, you can clean the room because there is not any dislodgement. There is no any accident here. And the last is that the shorter the time that you're exposed to the radiation, the better. So the absolutely safe period of time in which you can be exposed to the radiation without harm to your health is 30 minutes. So any visitor that is visiting the client uh, uh, um, should not be in the room receiving radiation more than 30 minutes. The same applies for the nurse. The nurse should not be in total per day more than 30 minutes in the room. It means that if you are going to give, I don't know, Tylenol to the client, okay, what you do, you prepare the Tylenol outside the room where there is no radiation, and then you enter the room where there is, yes, radiation, but you quickly give the Tylenol and you leave. And you you determine, you count how many minutes you spent inside the room. So maybe you spend 5 minutes. And then the next time you go spend 10 minutes. Now the next time you spend 5 minutes. Now the next time, you spend, okay, another 10 minutes. What means that? You reach 30 minutes. So you cannot enter this room anymore. Another nurse need to change the assignation to you, and you are not entering to this room more during the day, okay? So you need to plan your activities in a way that you only enter to the room the minimum possible with everything already prepared, with the idea of expending the least time possible inside the room. Okay, so the procedures and the care need to be simplified to expend the minimum time inside the room. To go in detail, the book says, your book, Technique Vicious, says that if your shift is the 8 hours, the limit is 30 minutes. But if your shift is 12 hours, in this case, you go to the hospital. If you have the shift 8 hours, you go to the hospital and in contact with the patient 5 times per week. But if your shift is 12 hours, you only go to the hospital to work 3 days per week. Okay, in this case, you can extend the time to 60 minutes. So 30 to 60 minutes maximum, depending of the duration of your shift and the frequency where you assist to the hospital, okay? To give you details. Here, I have a summary of this brachytherapy with internal radiation implant. Remember that it is a device that is placed in the cervix of the client. Is placed for 2 to 3 days, no more, and then is removed. Yes, and meanwhile, the patient has this device in the vagina. The patient cannot get out of bed, need to stay on bed. Can turn to the right, can turn to the left, can place in prone position, but cannot get up. Usually they place a Foley to avoid the travels to bathroom. They give a diet low in fiber to avoid the need of too much bowel movement. And the patient is going to be 48 to 72 hours with the implant on bed, cannot get up. If the patient get up, the implant can come out, and then it's an issue. So it's important. Remember that we said that this patient is radioactive, so need to be in a private room. Need to be in a private room, and alone. And the nurse that should be taking care should not be a nurse with contraindication of radiation, like pregnancy. Limits the shift, the exposition to 30 to 60 minutes. Always wear, this is the badge. You see the badge here, the dosimeter film badge. And each time you enter the room, you should be wearing a lead plomo. Lead is a metal that blocks the gamma rays, the radiation. So lead blocks the radiation. So if you are wearing a lead apron that always includes a lead collar to protect your thyroid gland, which is very sensible, very susceptible to radiation, this lead apron is only protected your front. So don't give your back to the client, to the source of radiation. Then there is a decreased possibility of having radiation in your important organs, like your breast, your genitals, intestines, etc. So always wear a lead, apron, okay? And trying to keep the maximum distance possible, as much as possible. I know that there are moments in which you need to approximate, but then you go back. Keep all the linen in the hamper in the room when they're removed to change the linen of the client, just in case there is an accidental dislodgement of the implant. And keep in the room a lead container with lid and long handles, tongues. So in case this radioactive implant, get dislodged accidentally, you can grab the implant from the bed or from the floor with the tongs and put inside the lead container, and then the radiation will be stopped and the emergency is controlled. Then you call the doctor, and then you call the radioactive environmental services that take care of this stuff to remove this stuff until the doctor decides to implant a new one again. This is what should be done. And that's it. The radiations, pee, poo, blood of these clients are not radioactive, aren't radioactive, okay? The only radiation that you need to be concerned that could be excreted in secretion is when the client take iodine, radioactive iodine for ablation of the thyroid gland for hyperthyroidism or for thyroid cancer. The urine can be radioactive. But here, this implant doesn't make the secretions, the blood, etc., radioactive. Okay, is the implant that is inside the body of the person the one that is radioactive. The nurse enters the room of a client with radioactive implant for cervical cancer and finds the implant dislodged and laying on the floor. What should the nurse do next? What you do first? Options. Pick up the implant with forceps, place in a lead container, and call radiotherapy department. Pick the implant up with sterile gloves, wipe with chlorhexidines, and reinsert in the vagina. Pick the implant up with clean gloves, wrap in the gauze, and call environmental radiation service to remove it. Leave the implant in the floor without touching it, close the doors to avoid radiation leak, and call the provider. What you do?
A.
Okay, easy. A. You take the implant with your tongues, put inside the container, call the doctor, call radiation services. So the best option here is A as an apple. Yes, A as an apple. You cannot take it with gloves because then you are going to burn your hands with the radiation. And you cannot ignore what is happening and just leave the client there and close the doors and not allowing anybody to enter there. If the client is in distress, is going to continue in distress, is not the good option. Okay, a variation of the same question. The nurse enters the room of a client with radioactive implant for cervical cancer and finds the implant dislodged and laying on the floor. What should do the nurse next? Take the implant with double gloves and put it in the lead container. Leave the room and call environmental radiation service to retrieve the implant. Throw the lead apron over the implant and call environmental services. remove the client from the room until environmental services retrieve the implants. What is the best answer of these options?
C.
I agree.
Sí.
C as in cat. In this case, what you are doing, because it's the best option, you are going to, you find the implant on the floor. You take your apron and you cover the implant with your lead apron. It's the equivalent of placing the implant inside the container, because the only other option that uses the lead container is taking the implant with the double gloves, and it is not correct. Need to be taken with the tongs, with long handled tongs. Okay, so C is the best option here. This is just to highlight to you that the same topic and the same question have many little teeny variations that makes the answer different. If any of you that are listening have been my student, you know that I used to do that when I make quizzes or tests for morning group and afternoon groups, that I just make little variations and now the answer changes. And if you memorize the answer without paying attention to the explanation, then you are screwed up. Okay, so it's just two examples of two different students that had experience with in their Nclexes and how the same topic and the same question changes the answer just with a little variations. Okay, another topic that I see frequently in Nclex, and not everybody knows this topic: toxic shock syndrome. Toxic shock syndrome is like a sepsis, and the patient develops a shock. So the blood pressure is very low, the blood is not moving, oxygen is not transported, cells are deprived of oxygen, the metabolism of all the cells of all the body deviate to anaerobic, and then the production of ATP is impaired, and a venom, a toxic substance, is produced in this anaerobic metabolism that happens in shock because the absence of oxygen. And then you have a lactic acidosis. You have a metabolic acidosis called lactic acidosis. Okay, this is a shock. And it's called toxic because it's related by substances, super antigens or super toxins that are produced mainly by staphylococcus or streptococcus beta hemolyticus. These super antigens, these super toxins produced by those bacteria penetrate in the body, and are going to overstimulate the immune system, producing a overproduction of defenses. I mean, those white blood cells and those substances produced by the white blood cells are called cytokines, and is producing a cytokine storm that overwhelms the body of the person and is producing a systemic inflammatory response, and as a consequence, a septic shock, and the patient se puede morir. And patient probably can die if it's not properly treated. So this is toxic shock syndrome. The most interesting of these is that it can be the first time that this syndrome was described in healthy women menstruating. So the menstruation, the presence of menstruation was the common factor in the initial description or discovering of this syndrome. And they also found as common in these women menstruating that they were using tampons. You know, tampons is this absorbent pad that is introduced in the vagina, very comfortable, very, very appropriate. And in those times, the factory of those tampons promoted the super tampons, highly absorbent, very high absorbent property in the tampon, in the design of the tampon, that allow the woman to keep the tampon for many, many hours while the woman was working out of home with, and then could be perfectly 10 hours, 12 hours with the tampon down there and without leaking because they were very absorbent, very super tampons. Precisely because those tampons were left for so long, then that were in this warm environment of the vagina, bacteria can overgrow and the staph of the skin or the strep of the skin can, overgrow, having blood there to grow, okay, which is the food, and then start producing the toxins that was absorbed in the wounded endometrium because the woman is menstruating, and the endometrium is shed when the menstruation occurs. There is a wound there, and then the women develop fever, rash, acute renal failure, hypertension and shock, and everything. And that's it. This is the story of the toxic shock syndrome. This also can occur in soft tissue wounds like infected surgical wounds, abscesses, cellulitis, etc. But we cannot prevent, we cannot educate anybody to avoid boils, abscesses, furuncles, cellulitis, infected surgical wounds because it's impossible. But we can educate women to avoid the super tampons and to change the tampons more frequently to avoid the toxic shock syndrome. And this is the most common question in NCLEX, if you understand this explanation. The most important is know that tampons should be bought small. So a tampon that cannot absorb so much blood that you can comfortably be with them without leak, okay, more than 8 hours. At least should be removed every 8 hours, preferably every 6 hours. And at night, when the woman is sleeping, should not be wearing the tampon, should be using external pad, because if the woman oversleep, then is not risk of developing the risk of that. And now this is what you need to know about toxic shock syndrome. Is clear? Okay, let's move. Which of the following is a probable sign of pregnancy? Auscultation of fetal heart tones, visualization of the fetal image on X-ray or sonogram, Goodle's signs, or amenorrhea. Who knows that?
D.
Okay, amenorrhea is a possible sign of pregnancy.
It's D. Good job.
Auscultating the fetal heart tones or seeing the baby is no doubt, is not probable.
True.
It's certainty, is a positive sign of pregnancy. So when you see the weird names, okay, the weird name sign, you don't need to memorize each one. When you see the weird, okay, the fancy, strange names in signs, Goodall, Chadwick, Haggard, Ballotment, etc. Those are probable. Yeah, probable. It's very probable that you are pregnant. Yes, the same as having a positive pregnancy test. Probable is no certainty, is not total 100%. A positive test is probable. Let's see, 90%, but still 10% could not. Okay. So these fancy names, okay, the Goodles, that is a soft cervix, Chadwick, which is a purple cervix, Haggard's, that you can touch, okay, the segment, one finger with the other, when you have inside the vagina and the other in the abdomen, Ballotment, when the uterus is big and you can play basketball with the uterus, the fingers in the vagina, the fingers in the abdomen. You're mira, mira, mira cómo hace. Okay, the pregnancy test is a test that you buy in the pharmacy and say positive. Okay, you know that a man. Do you know that a man can have a positive pregnancy test? Do you know that?
Yes.
Yes.
No.
Having what? A man having what?
Testicle cancer.
Testicular cancer. Testicular cancer. Testicular cancer can produce human chorionic gonadotrophic hormone, also known as HCG. And the presence of HCG, human gonadotrophic hormone, is what makes the test positive. Okay, and it is probable, but not certainty. It's not positive 100%, because even a man can have this test positive. Yeah, and the Braxton Hicks contractions, Braxton Hicks contraction, are uterine contractions that occur usually after the 20th week of gestation. Okay, so those are probable. Let's see, 90%. But positive, no doubt, 100%, no escape, okay? No alternative, okay? You are pregnant, period, okay? Is hearing the fetal heart tones, one, seeing the fetus in an ultrasound or X-ray, and three, palpating the fetal movement. Only three. Hearing fetal heart tones. Two, seeing with your eyes the fetus and an ultrasound of an X-ray. Yes? And third, expert hands palpating in the abdomen the different parts of a fetus, the head, the elbows, the back, and the knees. Yes? Okay? So, and moving, and those parts moving. Yes? Those are positive. In my experience, the ones that are tested more frequently in NCLEX are the positive. But look at this. This question was one student that I teaching all the time. No, don't learn the probable. Don't learn the presumptive. They never are in the NCLEX. Okay? After a week after I was saying that, the one that is always in NCLEX positive, this student had this question. Okay, a probable sign of pregnancy. Okay, you understanding me? No? If you don't understand me, ask me, because sometimes I think that people are understanding me and you don't understand. So there are 3 levels of signs of pregnancy and are tested. It's something that you need to know because nurses sometimes work without doctors in rural areas, okay, in the countryside, and you can tell a patient, well, probably you are pregnant, or definitive you are pregnant, and you need to go to the doctor to be checked. Okay, so presumptive is something that could be, let's see, 50% or 40%. Okay, like for example, you stop menstruating. But you know that many other causes of stop menstruating are nausea and vomiting. But you know, morning sickness are not the only cause of nausea and vomits of the person. Breast changes, the congestion in the breast becoming dark. This is the way that my wife always knew that she was pregnant. Okay, but it's not certainty. It can happen in other conditions. Quickening is feeling movement in the abdomen. It could be gas. It could be ¿cómo se llama? Worms. Okay, and those are not definitively so strong as those fancy names, as I said, which are probable, or the positive, there are 3, and they no doubt. So your signs of pregnancy, because it's a common question in English. And client refers her last menstrual period on May 23rd. When calculate the nurse her date of confinement. Confinement is the day of possible birth. No, confinement is a very old term of women when we were pregnant, and the moment arrived, they retired to their rooms. Okay, waiting for the birth. Okay, so when we have okay a question like this, we are going to use the Nagel rule. The Nagel rule says that when you have the date, okay, and then you have the date, in this case is May, which is the month 5, and the date, okay, that is 23rd, you need to subtract 3 to the month and add 7 to the day. So 5 minus 3 is 2. Yes, 2 is February. Yeah, and 23 plus 7 is
29.
30. Is 30, no? 7 plus 3, and llevo 1. 2 plus 1,
30.
3.
Yes.
Yeah, okay, okay.
Yeah, so we
Great.
March
So
2nd.
do we have in February 30 days?
No.
No. So you need then to move to the next month because you don't have the 30th of February. So now need to be the following month. The following month is March, no? March, no? After February, March, yes? But then February needs 28. How many days are on?
2.
2. So it's March the 2nd. Okay? So exactly like this, okay, was the scenario. So now it is a simple application of the Nagel rule. Subtract 3 to the number of the month and add 7 to the number of the day, of the date. And if it is a number that is a February and is a number that doesn't fit that, so you need to move to the next month in the days that are extra, okay, in this case. It's good, no problem. So summarizing, what you need to memorize for NCLEX. When they say the last menstrual period is a month that has a number, is a day that has a number, yes? So to the month, you are going to subtract 3, always 3. And to the day, you are going to add 7. Generally, with this is enough. But sometimes they give you weird situations, like the 30th of the February, okay? February the 30th, that doesn't exist. And then you need to adjust. So move to the next month, March, and the day that are extra there are going to be the day of the month, okay? So remember, this is the correct way of calculating the confinement or the date of birth. Right. Are you good? Another question that had been tested this way in NCLEX that you need to understand the same topic. The client has a date of confinement, October 14th. So her calculated with the Nagel rule, what we just did was calculated October the 14th. If today, suppose that today is September, September is the month before October. The 30th, which is the last day of September, how many weeks of gestation has this client?
38.
38. So this is the right answer. This is the right answer. So you need to know what you need to know. What you need to know, okay? Attention deficit disorder. Hey, what you need to know is that these Nagel rules calculate the week 14th. Yes. Pregnancy is a term between week 38 to 42. The middle is 40. Yes. So this Nagel rule, what calculates is the week 40. Yeah. the week 40. Okay, so week 40 is this one. So October the 14th, which is the date of confinement, the calculated date of confinement with Nagel rule is week 40. But if we are, okay, 2 weeks before, is 40 minus 2, 38. Everybody understood those two questions? Okay, those are the way of testing your understanding of the Nagel rule, okay, to calculate the probably date of birth or the 40th week of gestation. No problem. I hope that you are paying attention.
All good, Professor. Thank you.
Thank you. Is important, okay? Other topic that they ask a lot, if you know that at week 20th, you know, at week 20th, which is the mid of the pregnancy, the uterus should be more or less at the level of the umbilicus, belly button, or navel, yes? And more or less is at plus minus 2 centimeters. So it could be 2 centimeters above, 2 centimeters below, but at the level of the umbilicus. They test that many, many times. Why is so important the prenatal visit at 20 weeks, for example, a question? And the answer is because at 20 weeks, the uterus should be at the level of the umbilicus. What means that is too much higher or too much lower? That something is wrong and need to be reported, okay? Having the uterus, okay, below this limit means that the fetus is not growing properly, or the amount of liquid amniotic fluid is not enough. There is oligoamnios. Something wrong and need to be reported. Doctors need to find what is wrong. Having a too big uterus means that it's a multiple pregnancy, which is a complicated pregnancy, or is too much liquid, is a hydramnios, or is a macrosomic fetus, something wrong, need to be reported. So important to remember, at 20th week of gestation, the fundus of the uterus should be at the level of the umbilicus, plus minus 2 centimeters, okay? If you are going to measure the uterine height of a woman, what you do first before the woman go to the bed?
Empty the bladder.
Yes, it's a classical question, guys. Remember that for most of the procedures, electrocardiogram, lumbar tap, paracentesis, whatever, the important nursing intervention is take the client first to the bathroom to empty the bladder, and then, because for comfort and sometimes for safety. The only exception of this rule is when the woman is going to have an ultrasound of the pelvis, a pelvic ultrasound, and or amniocentesis, has less or is not pregnant or has less than 20 weeks of gestation. Okay, let me repeat. If a woman is going to have an ultrasound of the pelvis to see the ovaries, the uterus, etc., and could be also amniocentesis. So a needle is going to be guided by ultrasound to extract liquid, but could be because the amniocentesis or could be just because the ultrasound. And the woman is not pregnant. Or the woman is yes pregnant, but has less than 20 weeks of gestation. In this case, sorry, cannot be. Need to keep the bladder full. By the contrary, need to drink a lot of water to have very full the bladder, because the bladder is going to work as a contrast. The full bladder is going to work as a contrast to be able to see the ovaries and the uterus. You understand? But after 20 weeks of gestation, the uterus is already big and filled with water, with amniotic fluid, and you don't need the blood. By the contrary, it's be a hinder. It's going to be something that that brings problem. Okay, so it is something to remember. Very easy, very easy. I see that this item is important. You are supposed to know that a normal woman with a normal pregnancy, a fetus that is alive, should be feeling the movement of the fetus between the 16 and 18 weeks. I saw this topic tested in different ways many times. The main problem is that if a woman is not feeling these movements after the week 18, the fetus could be dead. Make sense? Fetus can die, okay, in the uterus, okay? And this is the main reason for memorizing that after week 16 to 18, a woman should be able to feel the fetal movement. There are certain changes in the physiology of the woman that are very marked, very intense in pregnancy. But the biggest change is in the cardiovascular system. In the woman is going to grow a huge organ that is the uterus, and inside the uterus a huge attachment that is the placenta. Those growing uterus and placenta are going to form new blood vessels, and those blood vessels need to be filled with blood. So the woman during the pregnancy is going to produce a lot of extra blood to fill these new blood vessels. And the woman produces a lot of more red blood cells in the pregnancy than when is not pregnant. A woman that is pregnant has more red blood cells than a woman that is not pregnant. Nevertheless, needs to produce plasma, red blood cells and plasma, and is producing more plasma than red blood cells. So even having more red blood cells, the red blood cells are going to be diluted. And for that reason, the hemoglobin tends to drop no less than 11, but tends to drop because dilution in the pregnancy. So there is a physiological dilution, not delusional, dilutional, okay, a drop of the hemoglobin is expected, no less than 11. But now the heart is the only heart that the woman has. Needs to move this extra bulimia, this extra plasma, and these extra red blood cells. So the heart is overloaded in pregnancy. A normal heart can deal with the situation. But if the woman brings, previous to the pregnancy, a problem in the heart, like a mild mitral stenosis, or I don't know, a mild to moderate myocardiopathy, then the pregnancy is going to show, is going to evidence the problem, because the extra work that the heart will have. Part of the normal extra work that the heart will have is that the heart rate must increase in pregnancy. So a woman that has a heart rate of 60, 70 before becoming pregnant, yes, will be increasing gradually the heart rate along the pregnancy until reaching 90, 98 beats per minute. Is physiological and expected. I already said the detail of the amniocentesis. Remember that amniocentesis is sterile. Amniocentesis is going to require ultrasound. Of course, if this before 20, full bladder, after 20, empty bladder. Remember that amniocentesis is local anesthesia. Is mildly discomfort. The pain is minimum. Remember that amniocentesis, the woman need to be supine, okay, with the abdomen exposed, but need to have a pillow a wedge or whatever in the right butt, in the right buttock, okay, to displace a little the uterus to the left and prevent the compression of the inferior vena cava. After amniocentesis is unacceptable, non-acceptable, having any leakage or leak of liquid need to be reported. After amniocentesis is unacceptable, need to be reported contractions or pain. And after amniocentesis, the fetus should be moving as normal. ¿Qué más pueden preguntar amniocentesis? Yeah, this is the stuff. I saw question of amniocentesis cerebral apply. And everything that I mentioned was included in this cerebral apply. If you know the details of the amniocentesis, you need to know that amniocentesis is done before week 20, generally before week 18, to detect problems in the fetus, problems that could require interruption of the pregnancy. So if the woman wants to know if the fetus is a Down syndrome or any other chromosomal alteration, or the woman is a carrier of a gene that could manifest in the fetus and could make a reason for interrupt the pregnancy, the amniocentesis must be done before the week 18 because it's when the pregnancy can be interrupted without problem, medical and legal problems. After week 20th, it's not logical to do an amniocentesis to interrupt the pregnancy. And for that reason, the amniocentesis that are done after week 20 is to see if the baby that is wanted, the baby that should be born, the baby that comes to the world alive is okay or is not okay. For example, the baby could be having jaundice in uterus, could be having suffering of any kind, but the baby may be still too immature, the lungs too immature as to be taken out. And for that reason, the lung maturity need to be stimulated or waited until ready. This is the reason for having the amniocentesis after week 20. A common question in English: how much weight should gain a normal weight woman? 25 to 35. Memorize that. Everybody has this question. It is a very repetitive question. So this is 25 to 35. To do that, a woman needs to increase the amount of calories, okay, that consumes from 300 to 500 calories extra. So it means if the woman becomes pregnant and is in the first half of the pregnancy, and she was consuming before becoming pregnancy a diet of 1600 calories, now is going to add 300 calories. So now is going to be consuming 1900 calories in the first half of the pregnancy. But at the end of the pregnancy is going to be more. So it's going to be adding, okay, 500 calories, okay? So it's going to increase in the last part of the pregnancy, 500 calories, okay? So now it's going to be consuming, 2100 calories. And if the woman gives birth and is giving breastfeeding, should continue adding these 500 calories during the breastfeeding period, okay? Okay. Women in pregnancy suffer a lot of heartburn and morning sickness. And they ask you, you recommend to that. For example, let's see questions that are being related. A pregnant woman who initiated pregnancy with BMI 21. Why I insist my student that you need to memorize the normal BMI? Because it's presented and you need to decide if it is normal, it is low, or is high. This is normal. From 18 to 25 is normal. So it started the pregnancy with a normal weight. And she's asking about dietary recommendation. Which of the following recommendations should the nurse advise? First option, at the end of pregnancy, the client should have increased her weight between 20 to 30 pounds. 2, the client should show an increment in the proportion of the proteins and fats. 3, the client should increase 500 calories the total caloric intake during the third trimester. And D, the diet should duplicate the content of calcium to prevent osteoporosis and tooth decay. What do you think is the best answer?
C.
C. I agree with you. So it should be 25 to 35. It is not correct. Yes, there is no need of increasing fats. Yes, proteins can, yes, need to be increased during the pregnancy. The protein, the iron, and the folic acid and the calories content need to increase, but there is no need of increment of anything else. Calcium during pregnancy has the same requirements than during non-pregnancy. There is not an increment of the need of calcium during, in the pregnancy. So the need of calcium before pregnancy is the same during pregnancy. This is a misconception that many women that are not nurses, are not reading the book, have. So it is a trap, it is a trick. Okay, exploring if you have been educated and you are not thinking like the lay people, you are thinking like a scientist. The next question, what of the following is a risk factor related to complication during pregnancy? 18 years old, low income, drink 8 ounces of coffee daily, or being vegetarian. The woman becomes pregnant, and which of these follow four risk elements constitute a risk factor for having a complicated pregnancy?
Low income.
The first one.
18 years old. Being vegetarian.
D.
It's A. I say
B,
A.
B,
The younger.
B.
No, low
B as in
income
boy,
don't
low
matter.
income.
A.
The stethoscope was invented in 1832 and became the
For me, it's
first
B.
innovation device that could
And listening the TV that has the.
it's like a really fancy.
Okay, I'm watching the TV. Okay. Okay. So notice that it is an interesting question. Okay. Some people think that being 18 is too young to be pregnant. Physiologically, biologically, an 18 years old woman is ready to become pregnant. And even can marry without the consent of the parents. And that's it. So I don't agree that being 18 is a risk factor for having a complicated pregnancy. I don't want to go in detail. This at 18, you are already graduated, etc. But it is definitively, I disagree with the selection of 18. 18 is okay to become pregnant. Okay. If you investigate your family backward, you'll find that I'm right. Being vegetarian is a misconception, and I know that Nclex explore if you have this misconception. A lot of people have prejudices against vegetarian or vegetarianism. A vegetarian, a vegan, obtains from the diet everything needed for children, adolescent, adult, pregnant women, surgery, convalescence, old age, etc. So there is not scientific evidence that a person that is vegan, a strict vegetarian, is going to have nutritional deficiency except only one, which is B12. And B12 is a vitamin that is stored in the liver and there is a storage there for almost 1 year. And B12 for vegans know that they don't have B12 in their diet. So they take a tablet, a pill of B12 to compensate this deficiency. Proteins can be found perfectly in a vegan diet. If you think there is no proteins in the vegetables, there is no proteins in the legumes, in the beans, there is no proteins in the nuts, there is no proteins in soy, etc. You are wrong. There are a lot of proteins in the vegan diet. All the vitamins except B12 are abundant in the vegan diet. Calories and carbohydrates are found in adequate amount in the vegan diet. Ask the elephants and the cows. And what else? Proteins, carbohydrates, fats. Okay, you can have a lot of olive oil, a lot of peanut butter, etc. in the vegan diet. The only nutrient that is deficient in the vegan diet is the vitamin B12, which is a vitamin exclusive of the animal kingdom. And for that reason, a strict vegan should consume supplements of B12. So please correct this misconception, because pregnancy, childhood, old age, convalescence, etc., is not a contraindication to a vegan diet. And it is in the book. So accept that for test purposes, even if you don't believe it. Most of the big vegetarian people like me are lacto-vegetarian or vegetarian. So just drinking milk or cheese or yogurt is enough source of B12. Okay, so many vegetarian people don't even need to take the B12 because they are lacto-vegetarian, etc. Okay, so I insist that you don't show prejudices against the vegan diet in Nclex, except for B12. Vegans need to take B12 supplement. There is no B12 in the vegan diet. It's the only missing nutrient in the vegan diet. So now is left with that. So now ruling out 8 ounces of coffee. Of course, Nclex is American taste. It is American coffee, and 1 cup of coffee, American coffee, is not bad, guys. The science says that it's not bad, and it's not contraindicated coffee in pregnancy. Only 1 cup of coffee per day is not bad. Is not a problem. Okay. So definitely, so yes, I agree. The science, the evidence, the statistics says that women that are poor, and in America, the women that are poor generally belongs to the minorities. In America, the minorities are the Native American, the African Americans, and the Hispanics. These minorities, okay, in America, okay, generally have more frequent low income than the white majority. And for that reason, okay, for cultural reasons, social and economic reasons, insurance, education, environment, sanitation, diet, etc., they found that when a woman that is pregnant is coming from these low income areas, especially minorities, they end with preeclampsia, they end with gestational diabetes, they end with drugs in alcoholism and pregnancy, they end with low birth weight, they end with miscarriage, they end with problems. And this is statistics, and makes sense. Okay, it was an English question. Okay, it was an English question.
Professor, I couldn't take a note. You said that the wedge pillow goes on the right side?
Okay, you need to know that anatomically, we have in the belly the vertebrae that are bones are very hard. Yes, vertebrae. This is the vertebrae. And then the spine, no, the vertebral column. And then at the right is a vein called inferior vena cava. At the left is a very strong blood vessel called aorta. The aorta cannot be compressed. You cannot make pressure in the aorta and collapse the aorta. Que va? It's very strong and the pressure inside is very high. But the veins can be compressed. If you take the veins of your hands and you push in the vein, they collapse. The same happens with this inferior vena cava. Remember that this inferior vena cava brings all the venous blood that is coming from the inferior part of the body, so the lower extremities, the abdomen, to the right heart. This venous blood should arrive to the right heart, okay, and then will be sent to the lung for oxygenation, and then will be sent to the left heart to give blood pressure and to give oxygenation of the uterus, the placenta, and the fetus. But then in pregnancy, you have a problem. Above this stuff, you have a huge uterus full with liquid placenta and baby. And if you are supine, boca arriba, it is going to compress. It's going to compress the inferior vena cava. So the venous blood coming from the right heart will not be able to pass to the right heart. So now less blood will go to the lung to oxygenate, and less blood with oxygen will reach the left heart, and less blood with oxygen will reach the aorta, and less blood with oxygen will reach the placenta. And who is going to suffer? The baby. The woman can have hypotension and fainting, dizziness, but is not going to die for that. But now the baby, because the compression of the inferior vena cava, and remember, this is right and this is left, okay? The compression of the inferior vena cava will produce fetal suffering, discomfort, yeah? If you place, and here come the buttocks, yes? If you place a wedge here in the right cheek, in the right buttocks, yes? The uterus will displace in this direction. Makes sense? So, because it's going to be a little higher, no? So the uterus will displace in this direction, yes? Releasing the pressure over the inferior vena cava, which is at the right. That's why you place the pillow in the right cheek to displace, even if you are still supine, you are still boca arriba, to displace a little, the uterus to the left and decompress the inferior vena cava. Do you understand the explanation?
Yes, thank you. Thank
This
you.
way you will never forget where you place the wedge. It's in the right cheek. Make sense? Okay. Remember that understanding avoids memorizing because memory has a limit. Nursing teaching in pregnancy and heartburns. So you have a woman that has a lot of heartburns. It's very common in pregnancy, the heartburn. Okay. So what you teach, let's see it is true or false. Yes or not? Eat 6 daily small meals. Yes or not?
Yes.
Yes, because
Yes.
it's the same recommendation for girls. You remember? Have a snack before bed. Yes or not?
No.
No, because now you produce acid because the presence of the snack and you have the regurgitation and more heartburn. Lay down on bed for 15 minutes after meals. Yes or not?
No.
No.
No, all the way around. Stay upright after meals for a couple of hours. Don't drink water, juice, soda, fluids with the meals. Yes or not?
Yes.
Yes.
Yes, because otherwise you are going to distend with liquid the stomach and it's easier than the regurgitation. Yes. take over the counter Mylanta, which is an antacid, yes,
No.
with your iron supplement. No, because then
Oh,
the iron is not going to be absorbed. Iron is very
It should
picky.
be.
It's too needed
It likes
in the
it likes vitamin C.
exactly, or orange juice or tomato juice. Remember, in English they always say tomato juice. Tomato juice has a lot of vitamin C. Fat in your meals? Yes, guys. The fats keeps the stomach full for too long and produce a lot of heartburn. Another example of questions, okay, how to deal. You know what is the Leopold maneuvers. You don't need to know in detail. I never seen that they ask that in detail, but they ask you, for what are the maneuvers, the Leopold maneuvers? Leopold maneuvers is to detect through palpation the position of the fetus in the uterus. If the head is down or is up, if the back is to the right or to the left. Yes? You don't need to know this because the test is not practical, so you don't need the four maneuvers, etc. Is this detail cannot be tested, but you need to understand that learning how to palpate the pregnant uterus, the gravid uterus of a woman, you can find where is the head, you can find where is the back. And it is very, very, very important because you are supposed to hear, to evaluate, to assess the fetal heart tones. You need to know that to hear the fetal heart tones, you need to find the back. Back is this stuff we have here behind under our neck, yes? The back of the baby, because you need to place the stethoscope or the Doppler precisely in the back of the baby to be able to hear the fetal heart tones. This is the place to hear the fetal heart tones. If you place the stethoscope in any other place, you won't be able to hear the fetal heart tones. It's clear. So now think a little. If you have a big belly, the pregnant belly at the end of the pregnancy looks like a football field. It's huge. And you have a point of reference that is the umbilicus. Yes, the umbilicus. And then you have possibilities. Having the baby with the head down or having the baby with the head up in bridge position. The most common, okay, like 90% of the birth is cephalic. Cephalic means head. And also the point of reference is the occipital bone. Doctors, when introduce doctors and experienced nurses or midwife, when they introduce their fingers in the vagina, they can touch if the cervix is already dilated. They can touch the occipital bone. They can know where is the occipital bone. That's why the cephalic or head position also refers to the occiput or the occipital bone. And it's important to localize the occipital bone because what you have beyond the occipital bone, okay, is the back. Usually we have our back under our occipital bone. Here is the occipital bone. If you go down, here is the back. So that's why it's so important to localize the occipital bone in the baby's face and head. If the baby is coming in bridge position, the bone, which is our interest, is the sacrum, because the sacrum is here in the back, and then we need to go up to find the back. If we know where is the sacrum, then we know where is the back. Yes? Summarizing, the secret to localize in this football field that is the abdomen of a pregnant woman, where to place the scope in to localize, to find the back of the baby, which is the place to hear the fetal heart tone, is to know if the baby is coming cephalic or bridge, and to know where is the occipital bone or the sacral bone. You don't need as an entry-level generalist nurse, which is the test that you will have. Nclex is the entry-level generalist test for nurses. Yes. You don't need to know how to palpate occipital or sacral bone. It's going to be given to you. So they will tell you the baby is coming cephalic, and the occipital bone is to the right or to the left. Can you understand that this baby can be, let me make it red, could be also in the other position. So could be like this, okay? Like this, okay? Okay, so could be in the other position. So the occipital bone could be to the right or to the left. And they'll tell you, that it come to the right or to the left. They will tell you with a standardized code that you need to know. They will tell you the baby is coming in O left A, or is coming in a R O A, or is coming in a left O P, or in a R O P. Okay, what means those letters? L means left. R means right. No problem. O means occipital. Okay, occiput. Okay, and A means anterior and P posterior. And I don't care. I don't care. I don't pay attention if it is anterior or posterior. It's not important for test purpose. So it's important to know if it is left or right, and if it is occipital. In case that the baby is coming bridge, which is very rare and poco probable, they will say RS, anterior, or left sacral posterior, yes, or anterior or whatever. And I don't care if it is anterior posterior. I care if it is right or left and it is sacrum. If they say occipital, it's because the baby comes, okay, cephalic. If they say sacral, it's because the baby is coming bridge. So now that you know the meaning of these letters and this terminology, you need to determine if you have a test, okay, that asks you where you place the stethoscope in a graphic question. You need to determine first what is right, which is this, right, and what is left, which is this, yes? And then you need to understand that if the baby is coming cephalic, the back need to be below the umbilicus. But if the baby is coming bridge, the back is going to be above the umbilicus. And makes sense. If it is the back and it is the back, yes, the back is after, okay, the head. So if the baby is coming cephalic, the back need to be below the umbilicus. If the baby is coming bridge, the back need to become above the umbilicus. And then could be at the right or the left. Remember that this baby could be having the back, the head could be here, but the back to the other side, okay? They can be in the position that they want. They can move, okay? Babies can be at the right, on the back, at the right, or at the left, yes? So for that reason, you need to pay attention to what they say. Is RR or is left, okay? So if they say right occipital anterior, I don't care anterior. So where is the back? The back must be below the umbilicus. Why? Because the head is below the umbilicus, yes? And must be at the right, so this is the side where the back should be. If they say left occipital posterior, I don't care the posterior, you know that need to be below the umbilical, but need to be at the left, so it should be here, the back. Okay? If they say right sacral posterior, I don't care the posterior, you know that the back need to be above the umbilical because the head need to be above the umbilical, but then must be here. So is here because it's at the right. This is the right, no? It should be occultated. So let's practice. Suppose that you have in the test this image, which is the abdomen of the woman, and they ask you, if the baby comes ROA, where you mark in which quadrant you place the stethoscope. This is our quadrants. Mark in which quadrant you place the stethoscope to auscultate the fetal heart tones. Then you say, the baby is coming.
Inferior, professor. Inferior right.
So,
Inferior
entonces,
right.
si viene
Inferior.
occipit, need to be below the umbilical, see? And it's right, where is it? Here.
Inferior.
And then you mark here. It's good? Everybody understood? This is right, this is the right, this is the left, okay? Right, left. They say there is right, need to be in the right. It's come occipital, below. Simple like that, okay? If they say left, occipital, whatever, I ignore this. So now need to be below the umbilical, but left, because it is left, yes? Need to be here. And you put the stethoscope here, you mark here. If they say, sorry, if they say, left sacral posterior, then sacral need to be above the umbilical. And left is here, so you need to mark this one. You understand? If they say anterior, is a little anterior. If they say posterior, a little posterior. That's why it's not very important, because they only ask to mark the quadrant where you are going to explore to find the fetal heart tones. If you don't know how to orient in this football field, okay, and you start, let me see this here. Oh no, let me see this here. Oh no, let me see this here. Oh no, let me see. You are lost, no? So it's very important that at least you can look in the correct quadrant. A 18 weeks pregnant woman called the doctor's office and informed, and you are nurse answering the call, and informed that she was exposed to rubella and wanted to know what to do. What statement is most appropriate for the nurse to tell the woman? A, assure the woman that in that stage of pregnancy, it won't affect the fetus. B, tell the woman to come during office hours to be evaluated. C, arrange for the woman to come today, but after all patients have left. D, advised to go to her PCP office and request the rubella vaccine before developing the rubella. What is the right answer for this question?
Maybe C.
Okay, everybody knows that rubella is a viral infection, a very benign viral infection for the woman, but could be devastating for the fetus. Yes? And it is important That's why all women should be vaccinated against rubella. Yeah. You need to know that this rubella can be devastating if affects the pregnancy in the first half, so before the 20th week. Okay? So after the 20th week is no problem for the fetus. Rubella in pregnancy after the 20th week of pregnancy, no problem. I repeat, it's tested in Nclex. See many questions of rubella in Nclex. Yes? Rubella after 20 weeks, no problem, no concern, no nothing special. It's a very benign disease. Tylenol, that's it, nothing else. Problem is 18 or younger, when still the organs can develop, especially the brain and the retina, and can produce, even the heart, can produce serious malformation. Are we good? It is an important learning because we probably think that in any moment of the pregnancy, rubella is bad. No, it's only in the first half, especially before week 18. Are we good? But for safety, we say week 20. So this pregnancy is still at risk with the rubella. Rubella is contagious. Rubella is airborne or droplets dissemination?
Droplet.
Droplets. It's the R of Spider-Man, yes? It's droplets. So it's contagious. So if this woman was exposed, okay, today, yesterday, to somebody with rubella, could be incubating the virus and could be having the virus could be affecting the fetus, or could be being spread, could be disseminated by the own woman. So this woman could be contagious, yeah? And of course, this woman need to be seen because it is an issue, having rubella in this moment of the pregnancy. But do you want this patient coming to the doctor's office, to the OB doctor's office that is full of pregnant women of different stages waiting there in the waiting room?
No.
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 That's why I agree with you that the best option is C, as in cat. Okay, you need to come, but you need to come after all the rest of the patients are already left. Only you.
¿Te puedo limpiarle el culo así?
Dios mío. Okay. So and it's recorded. Okay, so that's interesting question. Okay, some topics that I've seen that could be interesting, and remember that in pregnancy we cannot give the rubella vaccine during the pregnancy because it's live virus vaccine. Is the MMR, and it's live virus vaccine, and live but attenuated, weakened. But for the fetus that is immune suppressed, because all fetuses are immune suppressed, this weak, attenuated virus can produce disease. A woman that has been vaccinated with MMR cannot become pregnant until a month later because there is risk still for the woman. So this is a total no, okay, for this option. Good question. Which of the following pregnant clients should the nurse see first in the prenatal clinic? You are the nurse in the prenatal clinic and you have 4 clients. Which one is the maximum concern? 30 weeks pregnancy with severe heartburn. 18-week pregnancy who doesn't feel fetal movement, 38 weeks pregnancy with bilateral ankle edema, 37-week pregnancy with shortness of breath when supine. What do you think?
Sí. Sí, as in cat? Sí.
Okay, normally, ankle edema, you know what is the ankle, okay? Ankle edema is the ankle, no? Ankle edema is normal in pregnancy. So take care. Ankle edema is normal in pregnancy. If the edema is described in the hand, is no good. If the edema is described in the face, is no good. If the edema is described so severe that the trousers, the pants don't fit anymore, or the gown doesn't fit anymore, it's serious. Okay, so hands, face, abdomen, thighs, this is serious. But ankle edema or pedal is feet, no? And ankle is ankle, is expected. So don't allow this distractor catch you, okay? So we learned that, yes, it makes sense, but it's not. This is not a pathological. This is not preeclampsia.
It's
So,
B.
yes.
B.
B, based in the concept that at 18 weeks gestation, the woman should be feeling the fetal movement. And there is a possibility of having a fetal demise, a fetal that is dead. How you confirm or discard or rule out if the fetus is dead? You as a nurse.
Checking the heart.
Fetal heart tones. That's why you need to know this. Yes. If you find fetal heart tone, you say, this baby is too lazy, or you are too insensitive. Yes. But if there are no fetal heart tones, then you confirm it looks like the baby would be dead. Let me refer that woman to the doctor. Make sense? Those are questions and are common sense, basic entry level, basic questions. This is not rocket science. As until now, you've seen that they are just testing basic care of pregnancy. Having heartburn is something that is very uncomfortable, but not necessarily is bad prognosis. And a woman at 37-week gestation have a huge uterus that is reaching the level of the diaphragm. And when it's supine, resting supine, is going to have shortness of breath because the compression of the diaphragm. That's why women at this time like to sleep semi-fowler or always sleep lateral, never supine, because at least lateral, there is a relief of the compression of the uterus over the diaphragm. Okay, that's why the last one is not. Which of the following vaccines are recommended during pregnancy? Tuberculosis, BCG, varicella, Tdap, MMR.
C. No, A.
Tdap.
Tdap.
C.
C as in cat, Tdap. Tdap stands tetanus, diphtheria, and pertussis. Women during the pregnancy should be vaccinated with a booster of tetanus to increase the amount of antibodies against tetanus, because there is something called neonatorum. Neonatorum significa neonate, no? Neonate form, no? Neonatorum tetanus. Because remember that babies have a wound. Does baby have a wound when they are born? Yes or not?
Yes, the umbilicus.
The umbilicus, okay, the umbilicus. So the umbilicus could be the portal of entry of tetanus. So the baby is not vaccinated against tetanus, but is having the antibody from mom pass through the placenta. If mom had high levels of antibodies, receive a booster in the last part of pregnancy, in the last trimester, then the baby eliminates the possibility of this neonatorium tetanus. The pertussis, whooping cough, is a relative benign disease. I had that when I was a child. It's annoying because the cough is suffocating. But pertussis, whooping cough, is lethal in neonates. If a neonate catches whooping cough in the first year of age, can die. So again, it's important to elevate the level of antibodies in mama, so babies are born with high levels of antibodies, protecting them until their own schedule of vaccination protects them against tetanus and pertussis. Okay? MMR is live viral. No. Varicella is live viral. No. And in the United States of America and in Europe, Japan, Korea, and any first world country, they don't administer the BCG. Okay? They don't give the BCG. Okay? Please, for you that are interested in BCG, is administered only in the third world, in countries where tuberculosis is common. It is not useful in these countries. And BCG means bacilli of Calmette getting. Because in Nclex, when they use BCG, they don't write BCG. They say the vaccine of the bacilli of Calmette getting. And you need to assume that this is BCG, what they are talking. Okay? Are we good? No problem. Can we move? Do you understand the vaccines? Okay. Do you know what is this? Yes, ma'am.
Pregnancy? Should the Tdap be given to the pregnant woman? What stage in the pregnancy? The booster?
The booster is at the end of the pregnancy, in the third trimester. Yes. Okay.
Perfect.
Okay. Do you know what is a station? Baby is coming out. Is already in, the woman is in labor and the baby is coming. Okay. The baby starts descending through this hole is in the pelvis of the woman. Yes. And the anterior part is the pubis, and the back is the sacrum, and there is a hole there, and the baby is descending, is diving there. And when the doctor or the midwife introduces her or his fingers in the vagina, you can touch a prominence that you have in the ischial bone that is called the ischial spine, that is represented there. Okay, this level is given the value 0 for a station, and any level above this ischial spine, above is negative and below is positive. What I mean, in this picture that is represented here, the baby is at the level 0. But if the baby head is here, hago yo para que sea más grueso. Okay, if the head of the baby is here, then it's +1. Here, +2. Here, +3. So what means that? A baby that is +3, +4 is almost coming out. It's crowning, and you see the labia of the woman separating, and the head, the hair of the baby visible between the labia. So how is this applied to question? For example, one question in Nclex, very simple. 4 women in labor. Which one you see first? The one that is a station 4 plus. My goodness, is this coming out? You need to be there because otherwise the baby is going to be on the floor, you know? So those are examples. Another question in English. The woman has good contractions. One contraction every 3 minutes, lasting 90 seconds. This is the maximum. One contraction every 2 to 3 minutes, lasting no more than 90 seconds. Perfect contraction. And the cervix, okay, the cervix of the uterus is totally dilated at 10 centimeters, dilated, totally dilated. But the presentation, the head of the baby is negative, is -1, -2. What should do the nurse first? And then they had different options. Call the doctor, check if there is a late deceleration, bam, 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 bam. And the right answer was check for bladder distension. When the bladder is distended, even if the contraction is good and the dilation is perfect, the head cannot descend. Pay attention to this detail. Okay, it's an example of question that I seen in English. So what you know about monitorization of the baby? Babies can be monitored through their heartbeats, their heart frequency. And this monitorization generally is done externally. So 2 electrodes or 2 probes are placed in the abdomen of the mother. One probe, okay, one probe that is this, is to check if there are contractions, if the utero is contracting, because there is like a belt that surrounds the abdomen of the woman, and when there is a contraction, this is going to sense the contraction. This probe is called tocometer, TOCO meter, no? Tocometer. Okay. The other electrode is the one that is just a sticker that is sensing the heartbeats of the baby. Not the electrocardiogram, is the heart frequency, okay, the heart rate of the baby. So it's not the electrocardiogram, it's just the heart rate. And you need to know that the normal heart rate of a baby is between 120 and 160. Okay, 120 and 160. Okay, and this is what is called external monitorization, the most commonly done. Sometimes in high risk labors, when the woman is already in labor and the cervix is already dilated, at least partially dilated, and the membranes, the amniotic membranes, remember there are some amniotic membranes that surround, okay, the fetus, okay, and are closing here, but then can be broken. When there is the membranes are broken, the doctors can introduce the probes, both probes that I described before, the tachometer and the electrode for heart rate, can be introduced inside the uterus for a better monitorization. In this case, the electrode of the baby is going to pierce, is going to make a puncture in the scalp, a teeny little puncture in the scalp of the baby to anchor there. It's like a little screw, a needle with shape of a screw that is, is a screw there in the scalp. So there is a little puncture in the scalp. Nothing harmful, except if the mother has a bacteria or a virus that could penetrate them in this puncture to the baby. That's why this internal monitorization cannot be done if the woman has HIV, is a carrier of HIV, or carrier of hepatitis B, and infections in the uterus, okay? Okay, guys, I didn't notice how how much I was enjoying. I don't know you, but I was enjoying the stuff, but it's already 9. I have left to discuss with you next time that we meet the monitorization, because this is the other part that is super frequently tested in English. So I'm going to continue on discussing with you monitorization in our next meeting. Okay? Any questions? Any detail? Anything?
Thank you, Professor.
Professor, can you hear me?
Yes.
Professor, is this PowerPoint available to us?
I can publish this PowerPoint in the OneDrive, but remember that everything is recorded, so you have access,
I
and
know, but I know